and retired on November 30th. And next day, I'm a husband, a father. Kids are 25 and 29. Raised them. We're looking for the like grandkids. Grew up in Wisconsin. I lived in Chicago for 10 years prior to here, working at academic centers in Chicago and Russia. I did have 10 years on the national board for the Association for Men and Women as the president of the National Association. Still involved locally here. We've got a flyer over there. We're collaborating with the Hispanic Person Association for scholarships for Hispanic men. Greater Cincinnati, AM.
I'm actually it's 81. And I went around the block the long way. So I was a diploma nurse, then I went back on my bachelor's, then I went back on my master's, then I got my DNP, and they're all from different schools. And not one of my degrees is from UCLA. It's basically emergency for a long time. And in that role, I worked as a staff nurse, a charge nurse. At one point, I went to the manager of an ER. I was in a suburban area that was really busy. And after about the first week, I knew that this was not for me. But I had to try it. So that's when I went back to get my family nurse practitioner, which I did one for about 17 years. And I've always worked in occupational medicine. When I went back to get my FNP, I wanted to work at the ER, but at that time they did not have acute care, and I was advised to do family, so that's why I chose family. So when I graduated, it was kind of new. Nurse practitioner first new, and people really didn't know what we did. And I remember the ER director, he's like, well, you're going to come in, you're going to check the x-rays, and you're going to see if the reports match what was interpreted by the ER doc. And I'm thinking, well, that's really neat. And we have 7 hospitals that rotate shifts and weekends and holidays. And I'm thinking, I've done this as a nurse for a long time, probably like almost 20 years. But I had worked as a supervisor in occupational medicine. And I knew what that was like. I do a lot of injury care, which is like minors, cuts, breaks, broken bones. Although the other day I had a guy with 3 amputated fingertips. But Jeff, you want to open up a center up in Butler County? It's Monday through Friday, 8 to 5, with no weekends and no holidays. So that's why I landed in that role. And I've been there ever since. I've done a stint in a retail clinic. But I really have enjoyed my career and the ride that I've had. I taught some as an adjunct, and then at 15, I came here and started teaching full time. Still work one day at the weekend on patients. And I basically oversee the FNP students and those semesters.
My name is Greg Lagoche. I'm from Connecticut, Farmington, Connecticut. I came here for the BSN program and for the ROTC program. I was lucky to receive a scholarship my senior year, so that made it possible to come here. I never wanted to go into nursing because both my parents are nurses, so it was more of a, I don't want to be like them. I want to be my nurse, like do my own thing. But then I wanted to go into medicine, shadowed at a hospital, and what did I like? It was the nurse's role. So the communication with patients and patient-centered care, all that. So that's really, at that point, I was like, yep, I do want to go into it. But I enjoyed it all, and 3 months. So part of my 6 years to get an associate's degree, and then 5 years to finish getting a bachelor's. So it took me 11 years to get a lot of our students get in 4 years. But part of that was I got married as a teenager, so I've been married for 30 years. And so I grew up before, so like you just went to school and you had cash, and then I tried not to do that, and so that was kind of part of that problem. I think I was probably also just a slow learner to take 6 years for an associate's degree. But I got those up at Miami, and then I came here and got my master's in public health nursing and then my doctor of philosophy with PhD. And then I started working as a faculty member, and then later I went back to Vanderbilt and got a DPhil. So I have a broad spectrum of clinical experience. I started out on a telemetry care unit for a year, realized my ADHD is really hard to take care of the same person for 8 years. It's unsafe practice to have me in any kind of setting where the patient stays more than 3 hours. After that, it's a danger to their health and their ability to live. So then I finally got into emergency care and worked with Mercy System until the hospitals got shut down. Went to a different Mercy, and then I worked transport nursing for a while, and actually went to Children's for 7 years. And all that was predominantly emergency care setting, which is great because you can like go massage a heart, run over, take care of an earache, go over and help it in a chest tube, then go and like help somebody with med refills. So you don't have to think really long. You can think intensely for short periods of time. Then you move on to someone else and another issue. So that part was, it's great for the adrenaline, and it's also great if you can't focus for a long time, which helped me to really thrive as a clinician before I finally kind of landed that. And I've been here, I think I'm on my 15th year, and I've had the same thing. I started faculty role, assistant professor, eventually got promoted and did some program director for 2 programs. I became director, I had to shut them both down. So it's like, I'm kind of like the killer of things. So I've been a little bit hesitant becoming the interim dean because I don't want to be the one that like implodes the building. And it's like where people go first. So far, that's not happened. So I feel really good that we got it. So next, if we can just introduce, if y'all can introduce yourself as well, so we feel a little bit more connected. And if you want to just say your name, or like if you're in school or whatever you're doing, and if not, just kind of quick intro.
You're just starting, so I'm just here. But my parents were graduates of college of nursing, so kind of like just kind of coming down from like, a nursing background. So yeah.
Okay, my name is Henry Dia. I'm a second year of the PhD program. I'm from Ghana, and I'll say coming to nursing was like sort of a transition in high school. I was like, okay, now doing engineering and stuff, and then but after high school, I eventually entered nursing program. It wasn't all fun, to be honest. So, but when I started practicing, and I started to like the nursing practice, and I was actually working in a clinical research area. So, and I really love that aspect of as a nurse researcher. So, it sort of got my curiosity in nursing more than in the bedside. So, I did clinical research for about 5 years in Ghana, and then I had my public health, master's in public health, and then continued to work as a clinical nurse researcher, and then came in years ago to start my PhD in nursing. So I look forward to hearing from all of you the experiences and what I can learn as a trainee nurse. Thank you.
My name is Becky Smith. I'm a recent 2022 grad. I work over at the VA in their ICU. I am actually a current board member of the National Men in Nursing, so I'm like kind of here as supporting my UC Bearcats and as your mediator from the national chapter. Well, not the national chapter, but the association itself.
Hi, everyone. My name is Ann Gakumo, and I'm an associate professor and endowed chair for diversity, equity, and inclusive excellence at the College of Nursing. Nice to meet you all.
Hi, I'm Ryan. I'm a fifth-year senior here at the College of Nursing. Greg, and
I'm Anthony Ron. I'm a second career as a nurse. I was an engineer for 6 years, went back to school, got my degree, went to the emergency room at UC as my role transition, loved it, spent 20 years now at UC. Have in the last 4 years transitioned over to the flight nursing.
One of our first is tell me about the most exciting moment you've ever had. That's off the script. We could go into any. An exciting could just be a moment you felt really great. It doesn't have to be like bells and whistles. When I was still predominantly I had a shift in the PICU. A 5-year-old with neurologic changes. They didn't really know what was going on. And throughout the night, just felt like something wasn't right. And I kept on getting, wasn't really being heard by fellows or the residents that we had. And this night progressed, I just kept on getting something right. So I went to the attending, like, hey, this is what I'm feeling. Something's not right with this kid. His mental status changes they just don't add up to what I was painted during the report. So finally, we rushed down for head CT, and this kid has a head bleed. And luckily, intervened in time to save this child's life. And he was eventually discharged from the hospital. So that was probably one of those aha moments that I'm in the right place at the right time, and I'm here to make a difference. So yeah, that was probably one of my most big shifts, because I didn't take no for an answer, but I knew something wasn't right. Anyone else would like to respond to any questions?
This actually happened for a couple of weeks ago. It was my second day at children's CBIC with transition at night, and I was like the overflow side, so it's not really connected to the park. And it was pretty fun. But then they had investigation from the ER that they just sent straight up, and she had I guess it was like a heart transplant from when she was a few months old, and she was 2 years old now. And so my nurse was like, you go watch them and see what they do and everything. And then I walked up to the room, and then they quickly pulled me in and I put on all the PPE. And then they were like, all right, you're gonna do chest compressions. So I've never done them before. And I was nervous at first because it's your first time on a 2-year-old too. It's very tiny. And then I stepped up, and then the doctor's like, all right, pause compressions. So I'm just standing over this 2-year-old like while they're doing all this stuff to her. And then I finally started, and it felt like it. I didn't feel as nervous. But afterwards, seeing all the nurses work together, the whole healthcare team, it was just like that moment I'll never forget. Like, this is what we do. This is what I signed up for. And it just made it more real what I'm about to walk into.
Competition at the exam and #1 in safe delivery. But just always to see life when babies are born. I've delivered probably 6 or 7 babies. It's really kind of a very once in a while there is a hiccup. But the other thing, just most recently, I had a really good friend that had got diagnosed with stage 4 pancreatic cancer. And she only lived like 6 weeks, and she was my workers' comp case manager. We were very close. And her husband wrote in the MS one that he would, so did she. For the last couple of years, she couldn't. And so I could go over there because any time, and I was gone on a trip, and I came back and I really needed this CG, and I really needed this CG. Something kept saying I need to go CG. So I go over there on a Saturday. I said, I'm sure I can come. And I just knew it was going to be like imminent, her death. And it was just really peaceful because I took her hand. I said, Jean, now you know God's got this, and everybody's going to be okay. He had to go make a phone call. He says, do you mind if I make a phone call to my mom? I said, yeah, go ahead, because you'll be here, I'll be here, don't worry. So I said that to her, like, he comes back and her breathing, it just changed. And I know people can hear, and I'm not saying it was like anything, but I just think I've seen other people die, my mom, my sister, and I just think that's a thing as nurses we can do, especially if you're in hospice. But she died like within an hour when I was there. And her whole family was there. They were outside. We came in. It was just really peaceful. But I can see both sides, the birth, but also when you're able to help people transition into the next phase or whatever stage that is. We don't know what that is. But I really believe that I was told that I had to go there in that month of cold. And we were very close. It's very hard. I knew I was supposed to be there and I was supposed to help that family in her pass, and it was very peaceful. And I just think as nursing, a lot of times we don't see that part of nursing, but nurses deal with death and you deal with the family every day. And I think I just like that piece a lot. But I'm a very emotional person to speak to that. But yeah, but like the births and stuff, I just love childbirth. I went to Frontier for my DNP. So it's the home and midwifery in the United States. So, yeah, so I can see both sides. I think it's something it's an honor to watch a life being born, but it's also an honor to help that life pass. And I think as nurses, we're in that. And then sometimes we do get caught up into that and that's exciting too. It's like my background is PR.
It's a similar moment, I guess. I was, as a nurse practitioner, seeing patients, and I had a patient come in one time. She was a kind of elderly woman. Walked in the exam, sort of sitting, and I asked her what was wrong, and she said her back hurt. And I said, "What does it feel like?" And she said that she felt like she was getting hit in the back. And I'd seen a million patients with back pain a million times, and I didn't like the way she was presenting, and I didn't like the way she was complaining about her back pain. And I was concerned that she was having a dissection for play, and I sent her to radiology to get a CT. And the radiologist called me about 10 minutes later and said she had a huge PE. So my diagnosis was wrong. But presumptive diagnosis. But my instincts were right, and they sent her right to the ED. And if I would have sent her home, she would have died. So that was my good catch, I think, in my career.
The first one isn't really that cold. Obviously, like it's kind of interesting. So working on that 6, maybe 9 months as a nurse. 15 rounds, and I had this patient that came back from a cardiac cath to the post-cath care. His heart rate was going up, his blood pressure was dropping, he wasn't looking so good. Like I had this heroic moment of interrupting the team and saying, "I need you down in here to see this patient." Rush him back and carry him up, save his life. That's why that's memorable for me. I felt like I didn't really know anything at like 6 months into this career. I worked construction before I was a nurse. I was pretty good at, pouring concrete, but I wasn't very good at taking care of a whole patient assignment, kind of running up and down that hallway. And that the part that really made that memorable was the chief resident that was on the floor that day. Actually took time to do a conversation. What you did was really important. Don't ever hesitate to interrupt if something is important. To be honest, I wasn't what was going on, but I knew that I had to get some. The other one I would say is, what I really get excited about is working with or nursing students. So I probably should be a faculty guy, but I'm just not. I could do it part-time adjunct, UC doesn't really make that easy. So I have talked, but love working with students, undergrad, but graduate students. Graduate students are kind of like us. I want to be with them, like guys. Freshman nursing student, I mean, that's like golden. Let's support them, tell them how cool this is. So there's a guy named Riddell Smith at Cincinnati Children's. He worked in catering. And we had an opportunity to select him to work to go to a board to get his associate with Cincinnati State. And he did that. And he got his bachelor's at Ohio University. And then he got his master's as a psychiatric nurse practitioner. And this guy's life was just so different from his trajectory. This guy's working out in college, it's Cincinnati nurse practitioner, his own case, sees the kids. And then his son went to college on a basketball scholarship at Thomas More, and did a 5-year thing because he could play ball for the first 3 or 4 and then do the nursing thing the last 1 or 2. And just like this father-son nurse thing, it's just really kind of neat, especially from a gender perspective. Father-son. There's a couple other father-son figures. There's some brothers. There are a couple of alumni. When I see these 2 guys, Bill and Ed Olgar, if you know those folks, they both graduated from Mount Washington. They didn't answer any of my text messages or my private messages. And these guys are Bearcats. They should be here talking about, they're both football players. They're both like, what's that called when you're the king of this? Is it homecoming or prom? Homecoming. Yeah, they both are like, so like these football player, macho guys, but just have this tremendous compassion and care. And we could masculinize kind of like this gender thing in nursing, but it's really we've got both. Got this idea. You can be tough if you want, and you can be caring.
So I'll share 2 stories. I'll keep it kind of short. But one of them was, and I won't say where I was working, but I was in the emergency department. I was doing some transfers, and we had a Hispanic family that came in here, and they kind of sat in the lobby. And I went back and I was like, "Why is this timer like now? It's like all of a sudden 10 minutes, but people keep coming back." And so I went and said, "Like, well, what's going on? Like, why are they in the lobby? Why aren't they triage and treated?" It's like, "Well, they speak Spanish." I'm like, "I know you don't speak Spanish, and they speak Spanish, but there's things like there's language phones, there's a computer you can dial in." So finally, it's like, when I realized that was what it was, I just brought the family back out of triage. And then it was about having a conversation later and just talking about this is our expectation. And like, we need to treat everyone equally. Just because a person has a different culture, there's no reason to let them kind of sit out. And I didn't really know if the person really heard me until like about the next week. We're sitting at lunch. And then I hear them talking and they go, "Yes, he thinks I'm racist." And I was like, "What?" I was like, "When I walk into it," they said in HR, "Well, you said I was racist the other day." That's what I did. And I'm like, "Never said you were racist. I said your behavior was not appropriate and it was didn't show caring and compassion. And this is what you could have done, and these are the resources." And so then, like the whole lesson, we had a discussion about how to really triage people through, and if they don't speak the same language as you, this is the resources you have, and just clarifying what you can do. And it was just like kind of a gas that was the person's take-home message. Good part was the person got something from it. It wasn't the right message, but she did at least change her practice, and from then on, it was like getting people back. At least on the shifts when I was there, she was just moving people through. So it had the right outcome, maybe not the right kind of other piece. My other story is just, it's kind of like how Rich kind of says, you have your diagnosis. I'm not a nurse practitioner, I'm a CNS, so I don't diagnose. But you make assumptions, and when I was working in a pre-clinic, so after the city closes down, all the city clinics are closed, and the people who are homeless need care, they go to the emergency department. And so the goal of this clinic in the evenings was to keep people out of the ED and keep them from waiting 5 hours to find out, oh, that's just a hangout, you're going to be all right. Or you just need like some tender loving care. So a lot of what we did was just give Tylenol, ibuprofen, give a lot of shoes, we give a lot of socks, a lot of hygiene products, lots of dental care, and just kind of like, here, really, you just need some loving, and you just need to relax and take care of yourself the best you can be, living in shelter. But a couple of times where 2 people, one came in and it's like, "Can you help me with this?" And this was his finger. And I was like, "All right, let's get you to the emergency department because we don't reattach stitches in a clinic, a free clinic. There's no physician. It's run by a nurse practitioner from the university hospital. And the other person that came in, and it was because of my emergency background, the clinic director, she was like, what do you think about this person? I'm like, I don't know. Like, to me, I don't diagnose, but I think that they're dissecting their aortic organs. And I'm like, I would say call 911 and get him out of here. Because if I can drive, I'm like, you need to call an ambulance because what if he crashes? You need somebody to go and start light. And I was like, my diagnosis wasn't a real diagnosis. Boy, I sure felt pretty good. You know, we sent a lot of people going and having hemorrhages, like surgery to the heart, placing, like taking care of a heart attack. You felt really good, and of course there were a few people, and it was like, yeah, they sent them home like 2 hours later, but you just never know. But at least you feel like you're really doing something great. And for that, I wasn't getting paid. It really was just volunteering. I did that for about 7 or 8 years at the clinic, and it just felt. And that's something that we're trying now is to get the money from the donor to actually reopen this clinic, which is since closed due to COVID and kind of reopen my experience. So for me, that's kind of like this experience. Before I ask my next question, that's actually on the script. Do y'all have any questions for the panelists? All right. So what would you say you enjoy most about the nursing profession? And you don't have to say me, you can say something. That's no problem.
I always tell people that are contemplating nursing that you should never get bored. You should never get bored because there's so many things you can do. That's what I think I like the best. And I think just taking care of somebody, it's a good thing to feel like go home. That you made a difference.
Like a nurse manager, nurse educator, staff nurse. And I think one of these other things, like a lot of nurses work these 3 12-hour shifts, like who gets 4 days off? And any of your other buddies that finishing college, they work 3 days, have 4 days off every week. And get, full-time benefits and all that. If you want to pick up extra hours, then, it's 4 more hours and plus then is overtime. So lots of, you can make a reasonable income as a staff. And then just a variety of things. There's just such a vast variety of work. You can work at Cincinnati Children's, or you can work at UCLC, you can work at Christ Hospital, or you can work at the health department on the corner. They're just, and you can switch it up. You can change burrs without leaving. I worked in addictions care. I worked with adults. I worked with pediatrics and home care. And every one of those is almost like a little bit behavioral health now. Psychiatry wasn't somewhere I really wanted to work, and I kind of found myself having an affinity to the people and these the patients that you care of. It's just such a. I mean, one in 5, right? Have issues with mental health as children.
Clearly, both of you, flexibility and how you want your life to look, whether it be like a more traditional inpatient or patient care 9 to 5, or inpatient at the hospital, and then also just all the research and school, all the different pathways you could take. It's really appealing.
For me, I think the ability to impact someone else's life every day could be a coworker, peer, a patient, family, simply just taking a little bit of time out of your own day to do something for someone else is the most rewarding piece of nursing. And that's why I like to be a nurse. And every day is different. Every day is a challenge. Nurse for 4 years. I mean, I'm 3 kids in a single shift, which was really cool, especially for somebody that didn't really know what I wanted to do. That gave me a lot of different variety that I enjoyed.
So yes, 30 years I've done, a third of my career doing primarily direct patient care, a third of my career doing leadership positions, and a third of my career doing academia. I think now that I'm in my 50s and have been around for a while. That all of those things together are kind of made me who I am professionally. And I can sort of draw on different things at different times when I need to. And I kind of enjoy that now.
I have a question. So, can you give us some perspectives about the school, especially those who did the nursing maybe in the 90s? How was it like, or before the 90s? How was it like in terms of male ratio in classroom and by the general like perception male in nursing? What were some of the challenges that, or those perceptions? How would you manage those perceptions? I guess it's different from today, of course. So just if you can share your perspective about that.
I think I'm probably the oldest, well, the one that went through this. I think we only had 3 males in the whole school, and I finished, not that I'm, but it was very hard because there was faculty at the time, they were all women, that really, I felt because I was a male, I was looked down upon. You should be in medical school, or you should be doing whatever. I mean, I sensed that. And then like they did this big thing for women when during the OB-GYN rotation, like you had to go to the late J League. It was really pushed, but Jeff can't go. Not that I wanted to go, but it was like, but Jeff can't do that. Or in the LED, it was like, you want a student, a male student? I mean, it was kind of, I think things have changed greatly. I know they have, because I had students when I worked at Bethesda afterwards. It's totally different. I think just the whole, I think it's better than it was, but I just know that there was some faculty that were old school with their caps on, like shouldn't be in their. So that's my thing. It was kind of hard.
That was an outbreak.
Yeah.
It as an issue really at all. The only thing is like sometimes if there's a group project and there's a limit, like the guy is almost expected to leave because I don't know that from my experience. I don't know if you've seen that at all really, but like we're expected, I don't know, to do that. But otherwise, I've never really felt it being an issue. I feel like it's more about your personality. So if you're more of an extroverted person from high school going into nursing school that connects with professors and connects with people, you're going to be fine. If you're more introverted, but you could also be an introverted girl too, or woman. So in that sense, I don't see it being.
Just say 7 to 8 years ago, biased. I got involved because at the time I was the faculty advisor for the men nursing group. And I had a faculty member come to me and said, I need you to go and speak to these students because they're getting kind of out. And I was like, well, what are they saying? I thought, well, maybe they're just aggressive. Maybe it's because they're men, you don't like to just talk differently than women sometimes do. And it was because they had 5 women in a section and then 3 men. And they were doing physical exams, and well, they couldn't pair a man and a woman together, and they were asking me to change sections. And I go, well, did the woman say she was uncomfortable? She doesn't. I know she is. And I was like, but you don't really know that. You think that. It said, are all 5 women saying that because you could get a different student. Men can't touch women. And really what the whole overtone was that men are sexual predators. And that's how it felt to me. So it felt very wrong. And then I said, well, did you ask the woman to change sections? Since the woman's having the issue, could the woman change sections? Well, why would I do that? So then it just kind of became this thing. And then we finally had a college retreat like a few months later, because that was like in the spring. And for that, I actually went and spoke to the associate dean at the time because I was a regular faculty. He just said, this is what my concern is. I really feel like there's some bias. And the fact that these female doesn't think they understand what she's saying and how it's being perceived. And it's like telling men that they can't have the same experience. They have to accommodate when no one's actually asked for accommodation. Makes it harder. To me, it's all about the faculty has bias. And this person wasn't like 70 or 80 years old. I mean, she was probably about in her 30s or so at the time. So it was really kind of surprising. Her and I had a good relationship until that day. And then it just kind of soured for about a year or so. But I ended up intervening, and then the associate dean said, well, this should just, like, people need to learn how to touch. And when I was in nursing school, I went in the early 90s, and I didn't learn how to touch women. So we had to go in and do an EKG. Like when I worked in the emergency department, unless the person was unconscious, I was like, since you're a woman, we can go do her EKG and her catheter. A lot of guys do these things. They don't care about the rest of the violent people. As long as you go take care of this woman, you got to touch their chest or go into areas below the waist. And when I went to children's, and I thought that was the same, they were like, oh no, everybody takes care of your patient. I'm like, I've never capped a woman who was conscious. I got to go do a 16-year-old. It was like, I was incredibly fearful about that. Like, you just got to give them. Like, that's how it is here. And so it helped, but you need to learn how to touch women and touch men appropriately in nursing school. So that when you work with real humans out in the workforce, you can actually do it appropriately. So that was the thing we started talking about in our college. And then when our fall retreat came, we used to have a campus out past Claremont. It was like an old plane, and they called it UC East. But they had a big cow thing going, and they go, we like to call it the college of play. And I was like, they do have male nursing students. And some men might want to self-identify as female, but I know that a lot of them did not. So you just inverted, an assumption about men on women. If we did it to women, it said you're pretty masculine, and so we get upset with that if they believe they're very feminine. So that kind of bothered me. And during that same conversation, they talked about, we're all talking about like why we love where we work. I love UCEs because we're the college of women, and we kind of kept going on. And I was like ready to explode. And then the next person goes, I teach labor delivery, and I love it until all those guys all wait till the end, and all we're in the same room. Now what am I going to do? And I was like, what do you mean you're going to do? Like, you're just going to do then I've got to go and ask every person, would you like to have the male nurse? And I'm like, you should say the student, and they say yes or no. Because you don't go in and say this, I have a nursing student who is of a different race or different religion, is that going to be okay with? Because they know that's inappropriate. But it seemed to have been okay to do that with gender. And so after that sentinel day, the college had to go through a big healing process to kind of get over because I spoke up. And I think I spoke with a lot of tempered anger, probably. And I said, I used to love this place until today came, and then I just sort of like purged. And a lot of people, when I would walk down the hall for like 2 weeks, they'd shut their doors. But it was like we had to go through a healing process. And I would say since then, things have been much better. We've had a lot more inclusive practices. We still have, as a college, we have still a lot of challenges that we're working through. But I think where we were 8 to 9 years ago is much today. I don't know about the nursing students, if you feel the same or not, but that's been my perception of fact. Anybody else want to respond to Henry's question that's also old and want to talk about what it's like back?
Oh yeah, I have multiple perspectives on this. I think there was definitely a stigma in the 90s that's not as pronounced as there is today. Like I was telling Gordon earlier, like why do you I can think about the time that I was in my FNP master's program, and I was doing my women's health rotation. And my women's health rotation was at a nurse practitioner run clinic that was sort of a for women, by women kind of like vibe to the thing, and it's sort of marketed that way. And I remember that, I was learning how to do like pap smears, pelvic exams on women. And I remember that the women who were like my clinical mentors in that were like, hey, like, we want to teach you how to do this the right way because you're a man and you touch somebody wrong or say the wrong thing, like it'll get misinterpreted and you'll get yourself into trouble. So they said to me, like, we're going to be like extra hard on you about language that you choose in an exam and how you go about that. And in retrospect, like I can't tell you how much I appreciate that, that I was taught very sensitively how to do that exam. As somebody who was, when I was practicing all the time, I did like a couple times a day, something I needed to be good at. So I'm really appreciative of the fact that as a man, that there were women that were like, you need to be careful about how you do this, and this is how we recommend that you approach this. Finally, I would say there's still a few things that bug me. I think that when you look at strategic plans from national level organizations about how we need to increase the number of nurses because we don't have enough, society's getting old. I think a lot of times those strategic plans don't include like how do we go about including 37% of the population that's excluded. Like, what do we do to make men feel more comfortable being nursing? What do we do to market it? Like, there's none of that, and I'm not sure why that is. I'm biased or what, but like, why would you have a national level strategic plan to increase the number of nurses and not have one arm of that be like initiatives towards bringing men in the profession? I don't understand that. And there are some people that feel that, men, this is a woman's line of work, and that there shouldn't be any men that already are. Like, there's very definitely some of that. But I got to tell you that over the course of my long and mediocre career, that I've been mostly taken care of and had really good experiences.
So men tend to gravitate towards leadership positions as well as critical care, which is departments, anesthesia, and the like. Why do you think that is?
Well, men are relegated to certain positions. They're kind of sorted to the ER and flight and trauma, because that's what men would be good at. They're sorted to leadership positions because, and as you talk about through the group, you're going to be like a person's reporting out or something like that. Men should work in critical care, and these are all messages that are needed by faculty, by family, by society. This idea of maternity nursing, probably like the last frontier for men in nursing. It's like 1% of maternity nurses are men. And again, there's really good guys working there, but it's just not a spot like when you get out of high school, I want to be an OB nurse. It's just kind of unusual for that to be a recommendation. So I share this in part because I was a medical nurse, worked on medical work. Just loved working with these little people on adult care. Like, whenever I got one that was like my grandma, I like gave her special attention. You get to run to the mill and Dulles County and go on across the medical. You get soup to nuts, just really pretty much anything. People would always say, "Oh, are you going to go to the ICU?" No, I'm pretty happy here. You're going to go to the ER? No, this is kind of good. And it was always like, nobody ever said like I wasn't a good nurse or like I was underperforming or why am I not doing that, but those messages that were given subtly and very directly, like, no, you should be in a spot where like men should be going as a nurse. Brent McWilliams, he did his he worked on this and this idea that how men are kind of guided. So if you get into this, then once you get in, you're going to be like, you should work with the CBS Christ Hospital. That's a good spot for that. I mean, like, just in 3 months, it grew out to it. It moved on from the ER and the trauma to the flight nursing thing. I mean, that's a really great spot. So, like, these messages just get reinforced through the idea of working in women's health. What you described really, women that were inclusive to you as a practitioner, as based off your gender. There's a lot of stuff untouched in sexual predation, things like that. That goes under the curtain. It's not really like the textbooks or taught in the skills lab. I did, my doctoral work was on recruiting men into pediatrics. So you can say kind of thing like if you're a guy and you're working in pediatrics, like you get a little bit of pedophilia or something, kind of thing. Oh, I became a father. It's like the coolest thing for kids. But you work in pediatrics. I remember I did these focus groups, this nurse, this it's like some of this conversation with he had a conversation with family, focus. Like it kind of went south, like section. Like you're to care for the children, right? It's really affected by it. If the men in pediatrics, it's even a little worse, right? Because in adult care, you got to worry about people like catheterizing adults. But in pediatrics, I mean, little boys are little boys, that this society puts on that, because there really aren't that many women that use children sexually. So it's mostly, right? So if you're a nurse and you're maybe it's I used to think that maybe it would change, but it's the change is going. There's more men, and every year, every decade, we go up another percentage. So by the time we get to the next century, it'll be about 25%.
It's second time. We had 9, we had 8 males. Their students, so there were 8, and here's the lot, and then in nursing. In Thailand too. But I don't know if it's a US phenomenon. I don't know. Go ahead though.
We work in children's ED. But related back to like the OB and like maternity, never really share this with anybody, but my clinical, I had a slight misunderstanding with the nurse who I was shadowing, or not shadowing, but like assigned to. And she took it to an extreme, like, slight misunderstanding of like where we're supposed to be at what time. And she took me into the manager's, like she started like harassing me and berating me to the point where like I started to cry in like the nurse station. And she like took me to the manager's office, who's also my clinical like instructor. And she literally made me sit down and tell the manager the only way to get out of there was that I never wanted to work in OB, that I would never come back. That just killed that for me. So she just said, I was like crying. She kept saying, just say that you never want to work in OB and you're good to go. Forced me, but she was like, she kept calling me a liar for the misunderstanding. She's like, stop lying.
When that happened, you're right.
It was never on my list anyways, but didn't do that.
A bad OB experience one time with my nurse. I got there and she was like, wait like 30 minutes, I gotta eat my breakfast. And then she ate her whole breakfast. And then she just didn't really have me do anything at all. And then the next clinical shift at the UCMC, some of the other girls in my clinical were talking about what nurses we had before, and they were talking about my experience, and then they were like, oh, what was her name? And I didn't know they were talking about this, but I ended up telling her name, and then it started this whole thing on the floor. And it was just like unnecessary drama. Like I don't know, the manager ended up having to come out, and I was like, I'm sorry. Like, I don't know, it was just a lot, kind of like a toxic culture for everyone, or for me at least. I mean, in terms of them getting involved with it, like it was just banter happened type of deal. Just basically like the premise was I outed this nurse that I had last shift without realizing it because they asked me, this other nurse asked me who it was so she could joke around with it. And she texted her and she's like, oh, you're a student, said blah, blah, blah. So it just like caused unnecessary whatever.
The problem is that nurses, talk about nurses eating their young, I've never heard that phrase. And it's really a horrible, I'm sorry that y'all have this experience. And I've heard about, so this is not really course men in nursing tonight. We want to uplift you about men in nursing, but you know, that there happen other experiences related to other things that are distracting from your mind. So it's something that our college is very much focused on now. So as I hear these kind of things going on, we will as a college investigate. We've got good relationships with the chief nursing officer of the hospital to come and say, this is what we're hearing. We really need to shut this down. This is, if you really want more nurses to come here and work, having somebody to go back to the unit, that's why you're short staffed. That's why you can't get out of debt and hire nurses because you're creating an environment that's not good. And I'd say that different groups of people of different races, religions, and men tend to have harder times. And I just want to apologize for that on behalf of the profession that's also college.
We'll say I agree with because I think that maybe if my instructor says, Jeff, come on, we're gonna go get this woman, she just delivered. If you can get it in after somebody just delivered, you won't have any problems with anybody else. I mean, it was wonderful. I mean, she walked me through it. I was scared, shaking, but it was fine. I mean, it was just once in a while we did these little things to practice. Or the staff, the nurses on. Yeah. You have a question?
But it's here week. We have New Jersey. Shoot that bitch. But I wanted to just thank all of you because I think it's very different than what I wanted to. So thank you so much for sharing. And person in charge program facilitator. And one of our biggest issues that we have, of course, is male enrollment. And one of the big things that I've decided to help market our program is to talk medicine versus healthcare, because we know that versus healthcare and using those different terminology will make a difference in when you or sports medicine or things like that. Or someone saying that I know for myself in all of the different trainings that I all of the different certifications this year to see for Cincinnati State, but primarily had not ever considered some of the things that expressed that you go through or even to have the idea to equip our students with this type of knowledge. So I just want to thank you for expressing this because I definitely was like, and now that I've had the opportunity to listen, I just wanted to say thank you for that. It's never crossed my mind to typically hear it from the first end. And the most that we have equipped our male students with just understanding culture, because of course in healthcare, you know, you cannot have the So we're kind of more on that end of teaching, but I had never considered other parts that actually, which makes sense to me right now that I'm hearing it. Never considered it, so I just wanted to say thank you for it. And that there's even a panel in university. Or send them to.
But then, Jeff, Henry, but you don't think you heard it because you were grabbing it. That, like for in the U.S., in the profession, but his trips in Tanzania, and I think also Thailand, they have a higher proportion of minutes than people in the profession. And if you have any thoughts about that in terms of God, if that's the same or different.
So that's one of the reasons why I asked. I remember in my bachelor's class, we were essentially almost like 50-50. Yes. We were essentially 50, like for boys. So there's a lot of like men going into nursing. Of course, there is still that residual perception about men in nursing, but we seem to have seen a lot of male students and in the nursing profession, especially at the degree level. So that's what I saw, and I think the trend almost remains the same.
And you very, I think it's kind of common. And here you would not see a midwife, very low percent. I don't know, it's just interesting how it's different. I wonder if there's been any research or studies on why it's different. Anyway.
I was just gonna ask, like, Henry, you think it's like, how is it like, you said the percentage is higher, do you think it's higher because of the way that they like market what a nurse is, or do you think it's like a cultural difference between Ghana and the US?
So well, I don't know of the US, so I can speak to the Ghanaian one. So important point. So even in Ghana, midwifery is predominantly women. In fact, most of the midwifery schools you see only women. Just a few men who live into midwifery in Ghana. So in that area, nursing is still predominantly female. But for the general nursing at the degree level, we seem to be having a balance. And I saw most of the male nurses are encouraged to go for the degree as maybe as a stepping stone to perhaps leave the clinical setting or go into leadership. So I think all those nuances are.
I had an interesting observation. So I had the opportunity to go to Rwanda and Uganda to teach trauma military nurses at the time. And we had to make a special request for more females to be included because they were sending us just the males. And we had, of course, a team of both males and females, and we wanted to make sure there's a State Department program and representative and all that. So we made a special request to say, next class, can you send us more females because we need to have a mixed class. I'm like, oh, okay, we can do that. So I think they were preferential selecting males to come to this and seen as a trauma care opportunity, and they wanted, I don't know what their perception of why they wanted males to come to the program. But once we made the request, then it ended up being, classes.
You can tell us about post nursing as a profession, how you kind of got into it, and if you had to go back in time.
Had a long road, so both my parents were nurses, and then my dad became sort of assistant after that. And he
wanted me to be a physician assistant. So that's what I went to school for first. And I didn't really like it. I just didn't, it just didn't feel right. It wasn't a fit. And that's when I was like, okay, I'm at a crossroads in my life. What am I going to do? And I knew I wanted to help people, and I liked medicine a lot. So I chose nursing. And in that decision, I knew I was letting my father down, which was really hard. But it made me work 10 times harder in my profession and what I wanted to do. And I realized that I was really good at it. I was really good with people and interacting with others and really caring for people for a longer stint than just an office visit or in an OR or things like that. And when I chose nursing, it was for me. It wasn't for anybody else. It wasn't for my dad. It was for me, which is probably why I feel very fulfilled as a nurse. And it never feels like work to me. It feels like every day I can probably go to my job every day and enjoy it because I'm with people that I love to be around who also have a purpose to serve others. I think that's the greatest thing about nursing. You're surrounded by amazing human beings who are selfless, caring people. So. Oh, yeah, sorry, that question. Yeah, I was talking about earlier. I wouldn't throw 80 grand down the drain. Yeah, but yeah, I come to UC nursing much sooner than I did.
I have no regrets. I mean, would have both of my kids be nurses, but they don't want to be nurses. Actually, Katie, she wanted to be a nurse, but at that point, the admission requirements and the GPA were pretty high. She had good grades, but not like really good grades. So she got denied admission. She's a social worker, which is kind of right up her alley, and she likes that. I think my son Nick, who's 25 and English major, Bearcat, I think one day he might have a second degree as an ABSN. But when he realizes that actually money's a good thing to have. That's true. But yeah, I became a nurse. I was 14 years old. My first sister was 18. Rejected from a spinal cord injury. Not sure she was going to live for like 2 weeks. She's in the ICU, kind of like on the bubble. She would never die. So she was never going to walk again. She'd never have kids if she lived. They'd never have kids if she lived. And, so she's older than me. She's still alive. She's got kids and grandkids and walks with a crutch or a cane. But what I observed, what I was observing, but what I observed was people, the nurses and the physical therapists talking about how to treat the injuries. And they worked with her for a really long time, multiple surgeries. She was in the hospital for about 2 years. And then there was so I'm the second oldest. In the early 80s, there was a recession, and I was working at the trades. Dad wanted to be a carpenter friend since he was a carpenter and wanted to son. Then I was working in the trades as a laborer, and when that recession hit, home mortgages went up to like 24%. Construction jobs stopped. They weren't building buildings like this or the Bureau Institute or parking garages, schools, banks, or any of the construction stopped. So it was really just it was an opportunity to pause, and I got to do this vocational assessment. So I went to like the tech school for a week, did a bunch of tests and stuff. At the end of it, they said, well, here's the 3 recommendations: physical therapy, nursing, or mechanical design. So I enrolled in the mechanical design program. Nursing program just didn't seem like this. Physical therapy had like this really long wait list, and it's like you're sure if you're ever going to get it. And before that fall term, I was, an uncle was a psychologist or on a family vacation and actually talked about, I think I'm going to change careers. And he said, Bill, if I had to do it all over again, I'd do first. Like, dude, you're like, he was a department chairman. I didn't know what this meant at the time, but a department chairman at Temple University in Philadelphia, and I had published textbooks on his specialty. And like, really, you would do that? He's like, yeah, you could live in any city in the country. Or you want to live in Denver, or you want to live on the western slope of Colorado, or very rural? You want to live in Los Angeles or New York or Chicago, or do you want to live in a small rural town somewhere, or a mid-sized city like Cincinnati or Milwaukee, Minneapolis? You can talked about how many different things you can do as a person. I thought, and then I reflected back on the versus and differences. Started at the community college 1 year, 4 years there, 3 years at that 4-year campus. Like I said, I've got no regrets. I would do it all over again. I would do it differently, but I would do it all over again. And I would suggest to anybody, men or women, it's a pretty good job. But if you want to have a penthouse apartment, fancy cars, like really fancy ones, like $90,000 or $150,000, this probably isn't the right career path because it's really hard. But if you wanted it, you could have it.
I would do it however. I think I was influenced. Parents, the money's there, you can do whatever you want, but I wasn't really directed. My primary care provider tried to think about medicine, but I didn't want to do that. And I did all these degrees, but anyway, there was a nurse. Her name was Charlie Marie Yen, that was in our little town community, and everybody loved her. And she was the nicest woman, but she was very strict to it. And she drove a Mercedes, and her husband was a part of it. But they didn't have kids. But everybody respected her, and they listened to her, and whatever she said, Charlie Marie said it was like gospel. Like, I want to be like Charlie Marie. And then my aunt was a nurse. She actually easier shot down the road. It's great. This shots and stuff.
Like I kind of mentioned before, both my parents are nurses, and I wasn't influenced by them. It was more so myself finding that path through volunteering. And then I think I had a bio teacher junior year, and I was like, I want to go into pharmacy or medicine. And she was like, you know what, honestly, Greg, I started pharmacy school, and I don't think you would like it. You're just going to be stuck behind the counter, and that would just be a waste of your personality. I was like, and so that really got me thinking of nursing even more. And obviously, I'm not done yet, but I would do it over these 3.5 years.
Well, I mean, I've had a good career. Been challenged in every conceivable way I could be. There's been a couple of hard years in there, here and there, but it's been really good. It's been rewarding, and it's allowed me to take good care of my family. So appreciate it.
We have about 2 minutes left, so I just want to ask the panelists for any last kind of closing comments for us.
Okay, I thought everybody knows that we had an AAMN award winner in our presence here. Becky Smith is a student of the year.
I've had my time in Miami with AMN. Secretary, president, student of the year, youngest board member ever. I run up the membership committee and part of the conference planning committee, so I'm your gal.
Afraid of failure. I've been told on different jobs, been told that, you know, maybe you're not the right fit. The first leadership job I applied for was MPS. It would have been under Bill. And he told my director at the time, Lori, that I just didn't have enough experience. I wasn't there yet. And to be honest, I was pretty upset at that. But in the end, looking back, it was the right decision. And I wasn't ready. And I needed to do certain things to be well equipped to take over a leadership role. And it got me into, I need to get a graduate degree. Okay, so I'm going to go down the route. And I did it in a short amount of time because I was, set that I wasn't reaching my goals. But in the long run, really I should be thanking you for pushing me to where I needed to go because I just wasn't ready yet. But it was okay to put my foot forward and let people know I was interested in those leadership opportunities. Because ultimately I was going to get there. I just needed to go the right steps first. So yeah, it's okay to apply for jobs and not get them because you're going to learn something along the way.
For all of you here who are under, like, I got to do things that I would have never conceived that I was going to be able to do when I was in my 20s. And to be honest with you, things that I think if I would have known I was going to do, I probably would have been afraid. So it's just a matter of putting one foot in front of the other and being open to possibilities. And it's about like developing skills, getting education, and being open to possibilities when they arise. Sometimes it's not even having a grand plan, like my career to end here, this job, dean, or one of these CNO, hospital is just, it's building skills, keeping your mind open for possibilities that are going to present themselves. And then when you have one of those moments where you're contemplating a job, maybe you've been asked to apply, maybe you're applying and you have butterflies about it. Like, that's the universe, God telling you that like you're about to have a growth experience. It's not a moment where you turn and run. It's like those butterflies, that kind of nervous feeling that you have in your stomach. That's where you learn that like you're about to do something that you're going to grow from and embrace it.
Right. Don't get your bachelor's. Keep going and get your doctoral degree. Get it early while you have lots of years left to earn money off that degree. You don't have to be a researcher. You don't have to be a nurse practitioner. Use your degree and lead at the bedside. When I got my doctoral degree, I worked 4 more years at the bedside of children's ED. And people at times would say things like, wow, you seem really smart. You probably got your bachelor's. And I said, I do. Like, I wouldn't say I had a master's. She's like, yes, you asked about a bachelor's. I do. I was able to really influence care and do a lot of great things as a staff person. It doesn't matter why you've got your doctorate, but you can use that and get it early. And if you really want to go off and be a nurse practitioner, things, that's fine. But you can also stay at the bedside and keep making very clinical care and influencing that culture, but do it with the doctorate degree. Get it early so that you can really inform and transform the culture and workplace much earlier on in your career, make a big impact.